Hello, this is Michael Altos, and we are continuing our discussion of the GI system and antihistamines, and this is part 2. Now we're going to move on to the H2 receptor antagonists, and these drugs are really used in the treatment of GI-type symptoms. So patients who have GI ulceration, GERD, and as a pre-anesthetic medication to treat GI problems as well. H2 antagonists will inhibit gastric acid secretion and may actually decrease gastric volume as well. The drugs typically last 6 to 10 hours, and if they're taken chronically and then discontinued, we may see some rebound hypersecretion of gastric acid. Side effects of the H2 antagonists include diarrhea, fatigue, and headache. Rarely we see cardiac dysrhythmias or mental status changes. But we do see changes in gastric pH, which could alter absorption of some oral medications, and chronically could increase susceptibility to systemic infection. One of the early H2 antagonists was cimetidine, called Tagamet. You probably don't see this drug used as much anymore, and that's because it had a lot of drug interactions, probably due to its interaction with the cytochrome P450 system. It would increase plasma levels of all sorts of drugs like warfarin, theophylline, phenytoin, meperidine, nifedipine, lidocaine. You can see that would be pretty dangerous. It also increased estrogen levels. So I can't say that I've really used cimetidine as part of my anesthetic practice. More commonly, you'll see drugs like ranitidine or famotidine. Those are Zantac and Pepcid. And there's really no unique side effects or drug interactions with these medications. Their binding to cytochrome P450 is limited or just totally absent. So these drugs are dosed 50 milligrams IV for ranitidine, 20 milligrams for famotidine. They have a half-life of 2 to 3 hours, but the clinical half-life is more like 12 hours. So even though the drug is gone, the effects on gastric acid secretion persist for a little bit longer. So having discussed H2 blockers, we're going to continue discussing drugs that work on the GI system. And the next class of drugs are the proton pump inhibitors. These drugs inhibit the pump. These drugs inhibit the pump that transfers protons across the gastric membrane. And so they definitely have an impact on the acidity of the stomach. There's some questions about whether they decrease gastric fluid volume. Some studies have shown that, but the magnitude of the effect is debated. So I wouldn't personally rely on a proton pump inhibitor to decrease gastric volume, but it will, over time, certainly decrease the acidity. There are many, many of these drugs out there. I'm just going to mention a couple. Omeprazole, which is Prilosec. This is an oral drug. The effect takes 2 to 6 hours to start. It can last for more than 24 hours. Are you bored? And esomeprazole, which is Nexium, is an isomer of omeprazole. Lansoprazole, or Prevacid, has a similar action. There is a drug called pantoprazole, or Protonix. This is a potent, fast-acting drug which is available in IV formulation. So you may see patients in the hospital who are on a pantoprazole drip, or who are receiving it either for GI prophylaxis or for treatment of a GI condition. There are some studies that show that 40 milligrams of pantoprazole and 50 milligrams of ranitidine could decrease your gastric pH within about an hour. Now we're going to move on to some antacid drugs. Most of the antacids are salts of different metals like magnesium, aluminum, and calcium. And these salts neutralize the GI acid content with no effect on gastric volume. And you should be aware that if a patient is supposed to be NPO and they've eaten some of these salts, it is a particulate antacid. It's like eating a chalky substance. And so you may want to consider whether it's safe to proceed or if this is a violation of NPO guidelines. Examples of these drugs include sodium bicarbonate, which is Alka-Seltzer, magnesium hydroxide, which is milk of magnesia, aluminum hydroxide, which is Mylanta, and many mixtures out there, such as Rolaids, which is magnesium and calcium, or Maalox, which is magnesium and aluminum. We should be careful in patients who have renal failure because they may have compromised ability to clear these different salts from their body. There is an antacid which is non-particulate, which means it's a clear liquid, and that would be sodium citrate and citric acid, and it's called Bicitra. And this is often used in OB and other full stomach situations. This liquid does have an unpleasant super sweet and super sour flavor, but there are studies that show that when a patient aspirates gastric secretions into their lungs, the mortality from acid pneumonitis is decreased if the aspirate has a higher pH and a smaller volume. So when we give a non-particulate antacid like Bicitra, we decrease the likelihood of a foreign body reaction. And these are useful drugs because they have a very fast onset of action. So even though they do increase gastric volume a little bit, but they have a profound effect on gastric acidity, and therefore they're used routinely in full stomach situations. We're going to stop this recording here. If you have any questions, please let me know, and we'll finish up with the next video recording.